If we can shift gears just a little bit in terms of some MWMs for the shoulder area, what would happen, or I should say, what would you do, Brian, for a very specific AC problem? The patient that comes in and says, no, my problem is right here, very localized. Could you run us through a technique for that?
I'd love to.
Great.
Because I think I can tell the viewer of pathology that they might encounter. It's only rare, but you should be aware of it.
Right.
And that's a person that's got an AC joint lesion, and when they lift, abduct, they can't. They've got pain. They just can't lift. But ventrally, it goes all the way up.
Right.
Now, I can't believe this, but if you've got a patient, it's not common, but if you've got a patient that has this scenario, and you do what I'm about to show you, it'll give a click or a crunch or a crepitus, and they're instantly better. It's a one-off treatment.
Right. So if we quickly review the anatomy for the AC joint, we just use the AC joint so that we're talking about the distal end of the clavicle and the scapula.
The distal end of the clavicle and the scapula. And when you think of the pathology or the anatomy, if it's going to sublux, it can only really come superiorly. It can't go down. Its bone stops it. And it can't go back because it's jammed. It can go forwards.
Right.
Now, other things can happen in this joint, but I'm talking about this sudden onset of pain from doing something. And, they can't get it up, but they can fully flex. What do? You assume that there's some disruption of the joint, so you locate, in this case, the hypothenar eminence on the outer end of the clavicle, and you push it down and in. Because if it's going to get out of position, it comes up and forward. But when you push it down and
you've utilized a piece of foam here in this situation. What's the...
It's right over bone. And that's on everyone. If you're on that end of the clavicle or that end, that can be uncomfortable, especially when they're going to move the arm. So you stabilize the outer end of the clavicle. Now, while you're doing that, you ask the patient to swing their arm up freely. Now, where you stand is important, because if you stand here, you're in trouble.
Right.
They'll hit you.
What would the viewer need to know about what is the primary glide that you're inducing to the clavicle?
Well, in a way, it's a sort of rotation.
Okay.
It's a rotation. Now, a good point. When the arm is raised, the clavicle rotates.
Right.
It must. For the arm to come up, the clavicle rotates. I'm going to stop the clavicle from rotating. So what tends to happen is you get it's like a manipulation in that joint. It suddenly gets, it goes beyond the normal range of movement, and you hear a crepitus. And if you've got a...
So that's not necessarily a bad thing when we start actually hearing a little noise. It's moving again now.
No, and it's quite interesting. The AC joint, 50% of the population allegedly have a meniscus in there like the knee.
Correct.
And the other 50% do not have a meniscus. And if you take a normal patient like dear old Ed here, just lift up, there's a crepitus in there as he does it. And you expect that.
Right.
That means he's got a meniscus. Can you feel that when it comes down, that little grate just there?
Yeah.
That's right. Now, some people don't have a meniscus, and therefore you won't get that grating. And I believe that something happens to that meniscus sometimes. And there's some of it, it's just out of kilter. And once you do this, it rearranges it. Just a couple of swings. Yep. Now, you retest, and it's all better. Now, we will be talking a bit later, won't we, about the scapula. But the average AC joint, the positive sign is horizontal adduction. And that's painful right there. And we will do something with the scapula that can quite spectacularly, in most people, get rid of all that pain.
Motion as well.
So Brian, a couple of points on that. If you're doing that mobilization, do you find that altering the speed of how he elevates his arm is helpful as well?
Yes. If you want to get it to really sort of self-manipulate, if you like, you've got to have some motion.
So he gets more of a ballistic maneuver if necessary?
Yes.
I see.
And that motion, because it takes it beyond the normal range, it's just...
So we could progress this from a mobilization with movement to where you say, we need somebody to do something more vigorous and actually have them do an active manipulation.
Well, they're doing it.
So we've taken a look at the glenohumeral joint, and we've also taken a look at the AC joint. And we've got this whole shoulder complex, which isn't just those two bones. It's not just the clavicle and not just the humerus. You've got the scapula, which is the key, the cornerstone of the whole thing.
Yes.
So
this is new.
And this is kind of where you're heading with manual therapy in the shoulder. Would you like to kind of get into that with us?
Yeah, I can't wait. The basis for using mobilizations with movement is to reposition joint surfaces. And this positional fault, it can be measured in the between the tibia and fibula, but where you can see a positional fault is normally when you look at the scapula. Now, can you just swing around on that chair, please, Ed? Just like that, yeah. Here's the scapula. Here's the inferior angle. Now, sometimes patients come in and the shoulder girdle is elevated slightly, just slightly. It's up. You can see it compared with the other side. If you were to measure the vertebral border of the scapula with the spine itself, you'll find that not only has the shoulder girdle come up, it's rotated, and the whole thing moves laterally on the chest wall. So you've got three positional faults already. One is the elevation, the second is the rotation, and the third is the translation around the chest wall. And you'll often find with painful stiff shoulders that have been existing for a long time, they have pain down here on the lateral border of the scapula, and that's because the scapula is invaginating itself around in all this soft tissue, and it's just ripping into there, and that's tender to palpate and dig into. So you've got three things to correct when you're just looking at the scapula. You can see it's elevated, you can see the inferior angles come round, so it's rotated, and the mass of the thing of the scapula is moved around the chest wall. Something else happens. As it moves round, the angle here between the clavicle and the scapula increases. And sometimes you get a winging of the scapula, so that this angle here is increasing. Now, those three positional faults all affect the AC joint. If we've got this positional fault, which you can see where it's elevated, rotated, and it is glid around the wall, if you like. Glid's not a proper word, doesn't matter. And I've already mentioned that this angle here will increase because you get some winging of the scapula. Different things, all those changes of the scapula affect the AC joint. And I didn't realise that because for years I said two things can happen to the AC joint. It can pop up and forward. I never considered the implications of a positional fault of the scapula. And when that's come around, there's a rotation taking place at the AC joint. There's a gapping taking place. And there's a translation up taking place. Everything's going wrong in that AC joint when you've got a positional fault.
And taking that further, Brian, if you've got a positional fault in that scapula and the AC, what's happening at the glenohumeral joint in terms of impingement as well?
Well, even that can be affected.
Absolutely.
And one shouldn't be anecdotal, but the worst patient that I ever had to treat had her scapula was winging. You could put your finger underneath the scapula. It had come off the chest wall. She'd had 2 years of absolute misery. She was a black belt karate expert. And gosh, if she sees this, she's going to know. But she came from Seattle, which is in America.
Heard of it?
Yes. And she came to Wellington to see me because she needed help. She'd seen everybody and nobody could help her. And that lass had almost a paralysis of her serratus anterior. But she was a wonderful example. You could see all that I've just been speaking of so clearly. This angle had increased on top. You could see the shoulder girdle was elevated. You could see it had slid round the chest wall. But you just mentioned the shoulder joint. We had to do three things with her. We had to address the issue because as that was there, the humeral
head was forward. Okay.
So that had to be addressed. The repositioning of the scapula had to be, considered. And she had another complication. There was also a cervical involvement. So I had to treat the neck, the scapula, and the humerus at the same time.
So without getting the viewer too confused here, can we take a look? Can you go ahead and
show this technique?
Yeah, just give us the technique for that.
I deserve that.
No, this is terrific. But but let's get
now. How do you
basics.
treat it?
Yeah.
Show it. Get on with it. Okay, I've got to reposition that humeral head. Remember, the scapula. Just do that again. There's the spine of the scapula. I come out till I'm right at the end. Now, if I'm pushing down, that's going to correct the elevation of the scapula, and because I'm on the outer end of the scapula pushing, it will correct the rotation, and the other component is to bring it this way, so down, the rotation, and across. Now, we've got to also deal with this gapping that's occurring at this joint. So there, and in front, I'm on the clavicle medially, that's pushing in, everything's in target. Now, can you just lift that arm up for me, Brian? Oh, no, you can do it on your own initially. Yeah, goody. And down. If you've got an acutely sprained shoulder joint and involving the scapula, if you've got a stiff arm that's been there for some time, you need someone to give overpressure, which is important.
Okay.
And not only overpressure, while you've got an assistant, they can also translate the humeral head back, just gently, not too hard. Yes. So we've addressed any positional fault that may be in the shoulder joint. Just relax again for a moment till I correct the scapula first. There's the correction. Good. Now you lift that up, push it back and take it up slowly. And there should be no pain, Ed.
No pain.
No pain. Good. Any pain, you stop. Now, just back off. Sometimes there's a little bit of pain. They say, that's better, but I can still feel some pain. If that's the case, you might need to do more straight down, sort of pushing the scapula down. You may need to do a bit more rotation, or you may need to do a bit more translation towards the vertebral column.
So your physical exam before you start the technique is obviously going to give you that indication, and then it'll give you a direction, the preference that you want to head in. Sure.
You need some fine tuning. You might need the emphasis on one of those corrections. You might need a bit more pressure on the front.
Now, I'm feeling some stretching right through here when you do that.
Yes.
That's all normal, right?
Yes, yes,
Good.
yes. And what's more, you've got a normal shoulder, and we're stretching you and trying to make it an abnormal.
So sometimes we see in the clinic, you might see someone that has a glenohumeral problem, and you might get in there and do this initial first technique that we did, pushing back on the glenohumeral joint, and you might finesse that and work that and try to improve their range of motion with that. But if you strike out or you're having trouble still, perhaps you haven't looked at these other positional fault issues with the scapula, so getting after that impingement syndrome by going more proximally can be more effective in some of those folks.
Yes, yes.
Gentlemen, I think, Brian, that was an excellent presentation of how this technique sometimes needs a lot of details to the complexity of the scapulothoracic movement motion. Is it possible that some patients might only need one or two of those motions, and you need to change that a bit?
I did speak about emphasis, and sometimes when you're doing it, if you push straight down a little harder and think less about translating this way, they might feel much better. You might need to come more, bring the scapula medially, but you still retain the other components, but you just put a bit more emphasis on one. And the other thing is with people, if you've got someone helping you, they're taking the arm up, but they can use their other hand to help you reposition the inferior part of the scapula. They're helping you with the rotation component and the translation across. So just let that down a moment, just do that briefly. I'm right out on the spine of the scapula. There it is down and that way. That's in front. You are helping me. Excellent. Now, up comes the arm. And then down again. And remember, with all mobilizations with movement, it's the overpressure that makes it long-lasting. And if you don't use any overpressure, you'll get a result, but it won't last.